everyone. Welcome to the Win India webinar on nutrition in acute kidney injury. So there have been a series of webinars. I'm Dr. Swati Raju. I am Assistant Professor in JIPMA Puducherry, Department of Nephrology. I'll be the host for this session. So our goal today is to explore the various critical aspects of nutritional management in patients with acute kidney injury, and we have an excellent line of speakers and chairpersons who will share their insight and expertise on this important topic. So we have two sessions. First one is on nutritional alterations in AKI, and the second session is on how to feed a critically ill patient with AKI. And our chairpersons are Dr. Usha Samuel. Ma'am is a professor and Department of Nephrology at Government Medical College, Ernakulam, Kerala. And Dr. Binila Chako, Professor, Head of the Division of Critical Care at CMC Vellore, Tamil Nadu. And Dr. E. Indumati, Professor and Head of the Department of Nephrology at Savita Medical College, Chennai. So we will have these two sessions back to back, and the questions will be taken at the end of both the sessions. So everyone can post their questions in the chat box. So we hope that this webinar will provide valuable knowledge and insights and practical approaches to managing nutrition in patients with AKI. So I would like to invite all the chairpersons and to introduce our speakers. Over to the chairperson.
Yeah, good evening all. It is my pleasure to, first speaker is Dr. Priyamada, right?
Yes.
Yeah, so it's my pleasure to invite her to give this topic. The topic is, she doesn't require any introduction as she is a professor at JIPMER, well-known speaker at national and international level. And she is talking more on a lot of nutrition in dialysis, acute kidney injury, chronic kidney disease. And we all know about her. The topic is really needed topic because acute kidney injury with sepsis and AKI, this is what we are commonly see in ICU critically ill patients. And the nutritional requirements are really most of the time goes half as early, and some of them undernourished and some of them overnourished. So the nutritional, what are the nutritional alterations in AKI and how to assess, monitor, and what are the requirements and all we are going to hear from Dr. Priyamada. Over to you, Priyam.
Thank you, madam. So this is an overview of my talk, the nutritional disturbances. What is the basis of nutritional disturbances in acute kidney injury? How are we going to assess the nutritional status? And how actually we are going to feed a patient, a non-critically ill patient with acute kidney injury. Now, what we need to keep in mind is acute kidney injury comes with a specific set of issues, and it is not just the principles of nutrition. We are not going to just extend the principles of nutrition in CKD. So there are many determinants of the nutritional status in acute kidney injury. And in CKD, basically the most important determinant is going to be the patient's glomerular filtration rate. The stage of CKD, that is going to be the major determinant. Yes, like that, in acute kidney injury also, the stage of the AKI actually decides. It's one of the many deciding factors. And other factors like acidosis, presence of uremic toxins, whether the patient is on renal replacement therapy, what was the prior nutritional status of the patient, whether the patient is able to eat, whether the nutritional requirements are met. And there's a host of endocrine disturbances that happens along with acute kidney injury. But the major determinant of nutritional status is the severity of the illness that actually led to acute kidney injury. So from a nutritional standpoint, there is a catabolic acute kidney injury where the set of problems are going to be completely different. And there is yet another non-catabolic AKI, which is actually somewhat manageable, somewhat amenable to the routine way we manage nutrition. So when you have a critical illness, there are actually three phases of the critical illness. And in the acute phase, what happens is the body is basically trying to ward off, for example, if it is a sepsis, the body's entire efforts are focused at containing the infection or containing the trigger that led to the sepsis. So basically, in this early period, what happens is there is a general metabolic slowdown. And this might last for a day or two. And then that is followed by the flow phase, where the resting energy expenditure increases, the catabolism increases, and then this is followed by a relatively long late phase where actually the nutritional requirement starts coming down, and sometimes it can remain elevated, and at some point the catabolism is going to get low and the anabolism starts. So this is a little bit of an oversimplified version of what happens in critical illness, and again the same thing. So what happens when you have a critical illness is the total energy expenditure eventually at some point of time is elevated, and this elevation can be up to 170% of normal or maybe even higher, depending on the type of critical illness you are having. For example, someone suffering from NSAID-induced AKI, the basal metabolic demands are not going to be that much elevated. It may be marginally high, especially when we put the patient on renal replacement therapy, but that is something which is very well amenable with oral nutrition. On the other side, when you have something like a burns, which causes an AKI, the AKI per se is going to change things, and the major impact on the nutritional requirement is going to be caused by the burns, where the energy expenditure can be manifold higher compared to a regular steady state. So in short, the stress response, whatever happens with critical illness, it happens to a certain extent in non-critically ill AKI also. So there is uncontrolled catabolism going on one side, and then there is a resistance to anabolic signals. So uncontrolled catabolism, basically, it changes the way the body uses the macronutrients. And when a critical illness is complicated by AKI, there is a significant change in the way the micronutrients are also going to be utilized by the body. And eventually, if the catabolic signal lasts sufficiently long, this is going to change the individual's body composition. Now, when we decide on nutrition, it's of utmost important to decide whether it's a catabolic AKI or whether it is a non-catabolic AKI. So there are various definitions for catabolism. So the earliest and the most simplest definition is the rate at which urea is increasing. So anything more than 60 milligram per deciliter of urea rise in 24 hours in a patient with AKI, that is not something that usually happens. Usual rise usually might be much more lower in the 25 to 50 range. And when it is actually double than what usually is anticipated, that is considered as hypercatabolic AKI. But again, there are other definitions. Share et al. Sometime later came with an increase of 30 milligram per deciliter of blood urea nitrogen and a daily 1 milligram, more than 1 milligram deciliter rise in serum creatinine with some other parameters like changes in potassium, changes in uric acid levels, changes in phosphorus, and changes in bicarbonate. Any one of this criteria needs to be satisfied. But the most important, or probably perhaps the most useful way, is basically looking at the nitrogen balance. It's not an easy task. So normally the amount of nitrogen we ingest and the amount of nitrogen we excrete, the predominant one being in the urine in the form of urea, that always tally. Probably the amount of nitrogen ingested and the amount of nitrogen excreted, usually we tend to excrete maybe a few grams extra, 1 or 2 more than that. So now when the nitrogen intake and the gap between the nitrogen intake and nitrogen excretion is less than 6 grams, that is not a hypercatabolic AKI. And usually 6 to 12 grams, when actually the deficit is 6 to 12 grams, because nitrogen is actually coming from the food, the protein we eat. Now, if your body is excreting 6 to 12 grams of nitrogen in excess, that means only one thing: your proteins, or body proteins, are being broken down. That is considered as a moderate hypercatabolism. And when this nitrogen excretion exceeds the intake by more than 12 grams per day, that is going to be considered as severe hypercatabolism. The problem is in a patient who does not have any urine output, it is pretty easy because you need to substitute the time and the difference in the urea levels. For a patient who is on renal replacement therapy, things might get a little bit tricky because we need to know how much is the urea excretion in the dialysate also. So that actually sometimes certain erratic things might be coming, and Dr. Anusha will be explaining more on this nitrogen balance and all. Now, the metabolism of the macronutrients change, and it is going to change depending on the degree of the catabolism. So normally we know that kidney it's not a glucose dependent organ. So kidney basically depends on free fatty acid. The most metabolically active part of the kidney is the outer part of the cortex. And the cortex depends on free fatty acids. And when we come to the medulla, it is succinate and lactate, and only the inner medulla, that is the area which works exactly under hypoxic conditions, is dependent on glucose. So what happens to this glucose? So again, kidney has some other roles in glucose metabolism. Kidneys metabolize around 25 to 30 gram of glucose, that approximately equals 20% of the glucose removal. And the kidneys actually metabolize around 6 to 8 units of insulin. That again counts for around 30% of the insulin removal. And kidney is the second organ after liver which contributes to gluconeogenesis. On an average, around 15 to 50 gram of glucose will be produced in the kidney. So now, when we think that the kidney is gone, it's not just that this 20% of the glucose removal is affected, or 30% of the insulin removal is affected, or the gluconeogenesis is affected. But there are certain other changes happening in the kidney. The outer medulla and the cortex, which is dependent on alternate substrates, starts utilizing glucose more. And it causes a change in the oxidative phosphorylation to anaerobic glycolysis. So it is not just the kidney that is going to be affected in a catabolic state with the acute kidney injury. Let us say the classic example of NSAID-induced acute kidney injury. All these changes are happening, and still the metabolic derangements in acute kidney injury is sufficient to induce a transient state of insulin resistance. So basically, the tissues like muscle, which predominate the entry of glucose into the cells, is prevented. So rather than having hypoglycemia, hyperglycemia tends to be the rule in AKI, and this might not be manifesting that much in non-hypercatabolic AKI, but in hypercatabolic AKI, hyperglycemia is going to be the norm, unlike in CKD, where we tend to get more of hypoglycemia when the patient is being given insulin. Now, what are the factors? The problem is, I told you in the critical illness, there will be a phase where resting energy expenditure is going to be high. And the determinants of this increased resting energy expenditure includes the reason why the patient developed AKI, then other events happening in a sick patient like fever, the presence of hypothermia, changes in heart rate, shivering, agitation, some therapeutic interventions, sometimes the beta blockers. These are all factors that are going to raise the resting energy expenditure to a certain degree. And on the other side, there is gut malabsorption. And I told you there is already an insulin resistance induced by the critical illness perpetuated by the acute kidney injury. So the glucose cannot enter the cells. So eventually the net result is going to be hyperglycemia. Now, coming to the proteins. And again, the protein requirements are not going to be decided by the stage of AKI, but it is decided by the degree of the critical illness, the reason why the patient develops the critical illness, and whether the patient is put on renal replacement therapy or not. So as a part of critical illness, we have the cytokines, uremic toxins, insulin resistance, metabolic acidosis. Then some of these patients might be put on renal replacement therapy. Underfeeding is going to be very common. So there's inadequate supply of nutrients, there's lack of physical activity, and there is this proteasomal system that gets activated in critical illness as well as in kidney failure, which actually is a catabolic signal and starts breaking down the protein. So eventually, if the feeding is not given, or if the stimuli that leads to the AKI is sufficiently prolonged, the patient is going to enter a phase where the protein catabolism of the muscle protein catabolism is high. Eventually, it is going to reduce the muscle mass, and eventually patient is going to have less muscle strength also. So our lipid metabolism in kidney injury, hepatic and peripheral lipoprotein lipase activity is going to be reduced by at least 50%. So the consequence is there might be transient elevations in triglyceride, VLDL and LDL, but possibly in a non-hypercatabolic AKI, these things are not going to be of much of a consequence because an AKI is bound to resolve in a couple of weeks. But whereas in a critically ill patients, when we have to feed the patient on total parenteral nutrition, hyperlipidemia develops much more earlier in patients with acute kidney injury compared to someone without the kidney failure. And again, you will have a little bit of disturbances in cholesterol and HDL levels. But again, fatty acid oxidation is preserved predominantly because of the shift from glucose metabolism to other metabolic pathways. So this is in short what happens. Depending on the severity of the critical illness, you will have protein breakdown, you will have elevated glucose, and you will have adipose tissue breakdown also resulting in elevated fatty acids and glycerols. So eventually your lean body mass is going to be lost and there will be relative preservation of the fat mass. And these changes are much less pronounced in a non-hypercatabolic acute kidney injury. And in the early phase of the disease, we know that carbohydrate is a predominant substrate. Around 60% of the energy in a day is going to be derived from carbohydrate and the rest from lipids and from proteins. But what happens if you have a severe critical illness? What happens is the contribution of glucose as the substrate keeps on coming down. The contribution of fat as a energy substrate keeps on increasing, and same happens for protein. So now, again, the question is, okay, now if we actually reduce the glucose, give more protein and fats, whether the things are going to reverse? Unfortunately, the answer is no. Now, micronutrient alterations, it is a kidney injury that is going to decide the micronutrient alterations in acute kidney injury. So I'm not going to elaborate much because we are all nephrologists. We are dealing with all this on a day-to-day basis. So you can have dysnatremias, you can have hyperkalemia, hyperphosphatemia, hypocalcemia, hypomagnesemia. When the patient is on dialysis, you can develop vitamin B and other water-soluble vitamin deficiencies. If the patient actually stays sick for a couple of days, we can develop selenium copper deficiencies. And there is a tendency for zinc and aluminum to accumulate. But generally, all these things are not going to be much of a consequence unless the patient has a very, very prolonged hospital stay. Now, in a non-catabolic AKI, whether the patient is on renal replacement therapy is a major factor in deciding the nutritional status, because renal replacement therapy can lead to nutrient losses as well as gain. The conventional low flux dialysis we use most often is associated with a very negligible amino acid losses. It's just going to be 3 to 6 grams. So which probably might translate to maybe 1 or 2 grams of protein. Whereas on the other side, the high flux dialysis is going to lead to 8-gram amino acid losses, which approximately corresponds to somewhere around 5 to 6 grams of protein in a day. The problem is, when actually we are doing therapies like hemofiltration, the amino acid, the filter actually is big enough to leak these amino acids. And depending on the volume of the filtrate, the amino acid losses can be very high. Peritoneal dialysis also leads to around 5 to 8 gram loss of proteins. But in certain situations, the peritoneum can be leaky and probably the losses can go up to 20 to 40 grams in a day. And on the other side, there is some gain of calories predominantly from the glucose present in the dialysate as well as the citrate, which is acting as citrate can directly enter the tricarboxylic acid cycle. And on an average, around 200 to 30 calories can be gained from the dialysate dextrose as well as the citrate. So when we are prescribing diet for a patient, non-critically ill patient, on dialysis, we need to take into consideration the type of renal replacement therapy we are offering. And if you are using hybrid therapies like SLED-F, again, it has more nutrient losses compared to conventional SLED. Again, it's a function of the amount of fluid that is filtered. We have to take into account the nutrient losses with RRT as well as the nutrient gains with RRT. Now, the problem with CRRT is, especially the high volume hemofiltration and all, things become pretty unpredictable. And especially in regional citrate anticoagulation or the CRRT fluid containing citrate, we end up infusing quite a lot of citrate, either for anticoagulation or as part of the CRRT fluid. And a gram of citrate approximately equals to 3 kilocalories. And a gram of glucose approximately equals to 3.4 kilocalories. And if the fluid contains lactate, again, that is going to act as a nutritional source. So the problem is possibly when we use very large ultrafiltration volumes, like to the tune of 30 or 35 liters, the gain also can be pretty high. And this is extremely important when the glucose and lactate containing solutions are used in the post-dilution mode. When we use in the pre-dilution mode, at least some filtration is going to happen at the level of the filter. But when we infuse in the post-dilution mode, everything we infuse is going directly into the patient. So this is a little bit of a difficult task with CRRT because we don't really have a good predictive formulas for anything to take into consideration this calorie gain from various sources like citrate, glucose, and lactate. So only thing is this needs to be accounted. Otherwise, we might end up overfeeding the patient. Now, the general principles of nutrition in AKI, the macronutrient requirements are not decided by the kidney failure, but the underlying critical illness. That is again modified by the renal replacement therapy. And micronutrient requirements are modulated by AKI. So the micronutrient requirements are going to be decided by AKI as well as the presence of renal replacement therapy. Fluid requirements might vary on a day-to-day basis. And in a who is non-critically ill, probably and daily fluid intake accordingly. And the fluid prescription needs to be individualized. Now, so when to initiate nutrition in AKI? Those without hypercatabolic AKI, Dr. Anisha will be dealing. So those without a hypercatabolic AKI, there is nothing preventing you from prescribing the patient food. And patient has to be given oral energy dense feeds. And another thing is, just because the patient is having increasing urea levels, do not restrict the protein. The patient can be encouraged to eat a normal protein diet because invariably AKI's minimal amount of protein catabolism is going to happen. So there is no point in trying to restrict the protein too much in an attempt to postpone dialysis. And patients who we will have to make appropriate corrections. So there are different formulas to guide. Either we can actually adjust for the actual body weight. We can actually give a certain 33% allowance or so, or we can calculate the ideal body weight during BMI. So which method is better? We don't really know for sure. But only thing is that we tend to give reduced amount of calories when the patient is overweight. Otherwise, the patient is given energy-dense fluid, glucose-dense feeds are given to the patient. And in a non-catabolic AKI who is not on dialysis, the protein requirement are going to be like the general population. Kindly do not restrict the fluids. And a non-catabolic AKI on RRT, there is not much of evidence-based supportive guidelines, but the general tendency is to account for the amount of catabolism that is going to be induced by the AKI, the amount of catabolism that is going to be induced by the renal replacement therapy, and give around 1.1 to 1.3. And not more than 1.3 is recommended. Energy, minimum energy that is recommended is 25 kilocalorie per kilogram per day, and 70 to 75% of this energy should be derived from carbohydrates and the rest can be from fat. Fluids is going to be decided on a day-to-day basis. The electrolytes, most important issue is potassium. So these patients need to be on a low potassium diet. And once a patient is on dialysis, we need to supplement water-soluble vitamins, trace minerals, and some amount of vitamin C also. Then there are no clear-cut guidelines on supplementation of non-essential amino acids, because when you have kidney failure, some of the non-essential amino acids will become conditionally essential. So when the patient is on renal replacement therapy, again, we are losing these amino acids. There's a chance that actually the amino acids are going to be lost through the filter also. So generally, this is not an evidence-based guideline, but 2 to 6 grams of non-essential amino acid also needs to be supplemented. For most of the situation, if the patient is able to eat, we can actually meet these requirements through the patient's regular diet. Now, coming to assessment of nutritional status. So anthropometry is not going to be of much use in day-to-day prescriptions, but again, it's a mortality marker. Somebody who is going to be underweight has a very high mortality with AKI. The same thing holds for other things like subjective global assessment. If you come under class C, that is the worst, your mortality is going to be high. And again, these biochemical parameters, these are actually what we use in chronic kidney disease. These are not extensively validated in acute kidney injury. And again, there are quite a lot of nutritional scores available. I'm not going into detail regarding the nutritional scores, but the problem is these are all predictors of mortality, and that is not going to help us in prescribing the diet on a day-to-day basis. So now I'll just go back to the same thing, the resting energy expenditure, which I was talking early. So this is how the resting energy expenditure goes. There is a phase where actually it is low. Then there is a phase where it is high, and how high it goes depends on the reason why you developed AKI. And after a couple of days, it starts coming back to baseline. Now, this is actually an oversimplified model. But now the current models, it has been shown that the resting energy expenditure, it need not go up after 24 or 48 hours, and the extent to which the resting energy expenditure changes keeps on varying between patients with acute kidney injury. And again, contrary to the concept that it reaches the baseline in the recovery phase, sometimes the resting energy expenditure can remain significantly elevated in the recovery phase also. Now, the importance is that generally we have a tendency to feed intensively in this phase. And probably the intensity of the feeding might gradually come down in this phase. Now, if this is the curve, because of some reason or other, if this is the energy expenditure curve the patient is going to follow, this is the phase where actually the tail end of the illness phase is where actually patient needs extensive nutrition. And if we give that higher nutrition in this phase, assuming that actually it has gone into the flow phase, sometimes we might be overfeeding the patient, which is probably counterproductive. So now, how are we going to find out the resting energy expenditure? So this thing can be skipped when the patient is not hypercatabolic, but identifying the resting energy expenditure becomes extremely important as the patient is becoming more and more hypercatabolic. Again, there are a lot of predictive equations. Dr. Anusha will be discussing on this, but again, none of these things are going to be validated in critical illness, because these are all equations derived in the steady state. So, and in a critical illness, things are going to be changing on a minute-to-minute basis. The other thing is calorimetry, but direct calorimetry is basically a research tool, and it is not going to be of any use in a sick patient admitted in a hospital. So, if circumstances permit, indirect calorimetry is a method that is going to assess the resting energy expenditure in a patient who is admitted. So this is based on the simple principle that for we breathe oxygen and the carbon dioxide is given. And for each substrate, the amount of oxygen utilized, generally for one millimole of oxygen, a certain amount of carbon dioxide is going to be released, and that is always going to be less than 1. So this is something like the respiratory quotient. For carbohydrate, it is going to be somewhere around 1. For fat and protein, it is actually lower than 1. So now you have a scenario in which the respiratory quotient is going far above 1. That's not possible in the usual circumstances, and that generally denotes that this patient is having a higher degree of resting energy expenditure. The problem with indirect calorimetry in acute kidney injury, this is based on the assumption that lung is the only source through which the carbon dioxide is going to be eliminated. But what happens in patients with AKI is there is extracorporeal elimination of carbon dioxide. And when actually there is an extracorporeal elimination of carbon dioxide, indirect calorimetry the use becomes actually a little bit defective. And there are a lot of other situations in which it's not going to be useful, but no, it's not going to be accurate. But the major concern in a patient on RRT is the extracorporeal removal of carbon dioxide that might actually stand in the way of indirect calorimetry. And we have a lot of newer tools, but none of them is actually used in field. They largely remain as research tools. So to conclude, the fluid and micronutrient requirements are decided by AKI, and it again is modified by the RRT status. In non-catabolic AKI, the stage, rather than the stage of AKI, the need for renal replacement therapy decides the macronutrient needs. And the macronutrient needs are again primarily decided by the reason why the patient developed AKI, because if it's an NSAID-induced AKI, the patient is not going to be catabolic. On the other side, if it's a pneumonia with AKI, the patient is going to be a little bit catabolic. This allowances has to be incorporated into the prescription. And I'm not actually dealing with intradialytic parenteral nutrition. It's a general policy that many of us give intradialytic parenteral nutrition in AK, but that is a completely gray zone. There are no guidelines, no precedents or anything to recommend anything in anything regarding IDPN in AKI. So that's all. And the next talk, how actually to feed a patient, is being taken up by Dr. Anusha.
I'd like to welcome Dr. Anusha to take the session on how to feed a critically ill patient with acute kidney injury. Dr. Anusha is professor of anesthesia and critical care at JIPMER, and she's also the course coordinator for DM critical care, and I look forward to listening from her.
Hello, everyone. Is my slide visible?
Yes, yes.
Yes.
Yes. Yes. So thank you for having me today for this session. It was very interesting, the first talk, and I think a lot of what I would like to discuss is also partially completed in that. So without further delay, in the next 40 minutes, what we'll see is how do we actually deliver nutrition in a critically ill patient who also has AKI. So at the end of this topic, this session, what we would have learned is how to describe the metabolic and nutritional changes in a critically ill patient. What are the alterations when the patient has an AKI? And what are the current guidelines that are there for feeding a critically ill patient with AKI in the ICU? So let's go about a patient we have in the ICU. It's a hypothetical situation. 50-year-old man, 75 kilograms and 175 centimeters is admitted to the ICU following road traffic accident 24 hours ago, where he sustained chest injury with rib fractures and a flailed chest. He's intubated now. He's on a ventilator. He has lost significant blood from a pelvic fracture, which is now stabilized, and he has received transfusions. He doesn't have any significant past history. On examination, he's on ventilator receiving 70% FiO2, saturating 95%. He's getting a bit of NORAD at 0.04 mics, and BP is 100/50. Urine output is 20 ml per hour over the past 12 hours. His volume status seems to be optimized, and there is no evidence of fluid responsiveness at this moment. Blood urea is 50 milligrams per deciliter, and creatinine is 1.3 milligrams. So the first question that we have here is this patient at risk for developing a protein energy malnourishment? And in this scenario, are we going to restrict fluids and feeding in order to further avoid increase in urea and a fluid overload situation. So a lot of this has been covered already by Dr. Priyambada. Just to recap, when we have an acute stress response due to trauma or sepsis or burns or inflammation, within seconds, what happens is our sympathetic system and the hypothalamic pituitary axis inflammatory system, everything kicks in, and this pathway actually releases a lot of catabolic response in the body and releases cytokines and mediators. And what happens then is an imbalance of hormones, which are mainly catabolic in the form of cortisol, glucagon, growth hormones, whereas there is a a resistance to insulin. And so you have a lot of glucose, which is circulating in the blood. Over this, there is excess of hepatic gluconeogenesis happening because of all the catabolic hormones that are released, and insulin resistance is present. And this all leads to an uncontrolled catabolism in the presence of a lot of production of pro-inflammatory cytokines. So basically, your muscles are getting proteolized, and there are a lot of amino acids that are coming into the circulation, being taken up by the liver. And over there, it is preferentially, instead of being converted to albumin in the steady state, they're going to become acute phase proteins. So you'll have a deficiency of non-essential amino acids as well happening here. Then there is a lot of gluconeogenesis and release of glucose into the bloodstream. And there is an insulin resistance resulting in hyperglycemia. And the whole body actually starts to go into a protein catabolism state. And in this phase, the body itself can generate around 50 to 75% of its own glucose requirement in the acute phase. So it is a situation where there is increase in glucose production. However, the catabolism at this phase, the energy utilization is very limited, and it's not optimal because we have a lot of insulin resistance and all going on. And also there is lipolysis, which releases free fatty acids, and they undergo peroxidation with reactive oxygen species. So in the presence of AKI, the hallmark of AKI metabolism is the protein metabolism, and there is dysregulation in the amino acids that are being going into the circulation, increasing the proteolysis. There is impairment in the proper utilization of exogenous amino acids that is being given. Then the other thing is the glucose metabolism. We know that the kidney plays a central role in the regulation of glucose, and this gluconeogenesis and insulin resistance increases the hyperglycemic phase. There is a reduction in lipolysis, as Dr. Priyambada had told us earlier, and this leads to an increase in triglycerides that are circulating, and this again has implications when we feed these patients. So also there is depletion of antioxidant systems in AKI, then induction of a pro-inflammatory state, immunodeficiency, plasma concentration of water-soluble vitamins is reduced, vitamin D activation is impaired, E, A, selenium levels are low. And over this, if the patient also has a CKD, then the catabolic phase and the inflammatory phase that is already there with CKD is going to worsen. So in short, what happens, why there is protein energy malnourishment is AKI is never a single entity in a critically ill patient. It is due to or exists along with other inflammation or comorbidities. So in the presence of AKI, there is inflammation which is happening and metabolic acidosis, which leads to more proteolysis and an intense catabolic phase. While because of the AKI, there is anorexia, nutrition support is not adequate because we don't know what is the weight of this patient, how much to feed this patient. There is an underestimation of their requirements, the limitation of protein intake. All these leads to an insufficient intake, while there can be an increase in requirement once we start the renal replacement therapy due to the loss of these substrates. So ultimately, we have a condition of protein energy malnourishment in this patient. So further, this protein energy malnutrition leads to further utilization from the lean body mass of the patient itself, leading to poor wound healing, impaired ventilation, impaired organ support, immune defense is compromised, further increasing the chance for infection, sepsis, multi-organ failure, and mortality. So there is an option here. We have an opportunity here to give optimal nutritional therapy to improve this situation. Mind you, at the catabolic phase, by just providing nutrition adequately, it is not going to stop the process because it is basically the pathology itself which has to stop, but we have to support them by giving optimal nutrition, which we will see soon. And there is no evidence as of now for specialized nutritional therapy, but it is probably going to be helpful in the future. So as we saw in the previous class, session, that we can divide the acute phase, I mean the acute stress phase into three phases. The initial acute phase is divided into two, the early phase and the late phase. The early phase is where there is a lot of catabolism happening, but the metabolic rate and everything is actually reduced. And the importance here is that we should not be overloading the patients or giving them the exact and the high amount of the nutrients that they need. Because at this phase, they will be producing nearly 500 to 1,500 kilocalories of their own from metabolizing their own body. So if we are going to give more nutrients here, it is going to be deleterious for them. Then this phase is characterized by a patient having a high inotropic support and in organ failure and all that. And then finally, they go into the second phase after 24 to 48 hours, where things start to transition to a more controlled type of situation. And then at that time, you can start giving them more nutrition that they require. And then finally, after a week or so, we see that they are going into more of an anabolic phase, where again, we need to support these patients intensely with nutritionally so that their recovery is faster. So benefits of nutrition, they improve wound healing, decrease the catabolic response, enhance immune system, improve the GI structure, improve clinical outcomes, reduce the complication rates, and further they decrease the length of stay, which is accompanied by cost savings. All these have various studies that have been done, which are available. So in our patients, should we now that we are going ahead, we're going to have a nutrition plan for the patient. Should we assess for nutritional risk and stratification? So it is very important to stratify and see the nutritional risk for this patient, because if we identify patients at high risk of nutritionally high risk, these are the patients that benefit most from early nutrition. So screening means we find the patient who are at the risk for nutritional risk, and assessment means we are going to evaluate how much is their nutritional status. So according to the ESPEN guidelines, which I would be alluding to here, every critically ill patient staying for more than 48 hours in the ICU should be considered at risk for malnourishment. So we look for a risk for malnourishment in every patient. There are no concrete tools that are available, certain ones which are available as of now. So we go by history and physical examination. What is their weight loss in the past few days or weeks before ICU admission? What has been their physical level of activity? What is their body composition, muscle mass, and strength? There are various scores like what Dr. Priyamada had told: Nutric score, subjective global assessment, malnourishment, universal screening tools. These are all, they have all correlated quite well with the mortality and prediction of the outcomes in the patient, especially the subjective global assessment score. But the best among them is the gold standard is the indirect calorimetry. Quantification, how do you quantify the loss of nutrition in these patients? These are all not very feasible, or they are still in the development phase. The ultrasound measurement of the muscles we can do, especially the vastus. But again, we don't have any standardization here. Bioelectrical impedance. Here, the problem is we can only see the change in water and not the lean body mass. Then imaging, we can do CT, MRI, which is again not practical in a critically ill patients. Here we can actually quantify how much is the subcutaneous fat, how much is the water content, how much is the fat, etc. So these are a few of the things like subjective global assessment takes into account history and physical examination, and we have a score of A, B, and C. Malnourishment universal screening takes BMI, unplanned weight loss, and the acute phase, and the total score is given. Nutric score we have based on the acute phase of the disease with the age. The actual Nutric score takes IL-6 into account, and based on this, there are high score and low score. High score is associated with a higher incidence of mortality and ventilation. These are patients who benefit most from aggressive nutritional therapy. Without the IL-6, we have scores as well, which have the same implications. So these are the various things that we have with us: body composition by CT scan, ultrasound, and bioimpedance. So this is, as the SGA class is worsening, the mortality rate is increasing. So these are several markers that we normally use in a stable kidney injury or any other patient. But as you can see, there are limitations for using these as a marker for nutrition in the ICU, like albumin. There could be several other reasons that the albumin is low, anthropometry, and etc. So the basic thing is every critically ill patient staying for more than 48 hours in the ICU should be considered at risk for malnourishment, and we should have a plan for their nutrition in this time period. It's good to see if patient is at very high nutritional risk. This is a weight loss of more than 10 to 15%, BMI which is low, SGA grade C, and albumin low, because while feeding these patients, we should keep in mind that they are at high risk of refeeding syndrome. So the next question is, when should we start feeding this critically ill patient, and what route do we take, enteral or parenteral? So according to the ESPEN guidelines, we start clinical nutrition as soon as we can, or the patient can. You always start with oral nutrition. If oral access is available, go ahead with it. If it is not available, we look for any contraindication to use the enteral route. So enteral route is the preferred route. If there is no contraindication, we go ahead with the early enteral nutrition. If there is contraindication, we look and screen for malnourishment. In the presence of malnourishment, using whatever scores of physical exam that we went through now, if there is malnourishment, then we have to start early parenteral nutrition. So this is the role for parenteral nutrition in a severely malnourished patient or who is at risk of malnourishment. If the enteral access is not readily available, then we go ahead with parenteral nutrition. And if there is no malnourishment, then we can wait and delay up to 3 to 5 days and reassess again whether we can use the enteral route again. So medical nutritional therapy shall be considered for all patients staying in ICU, mainly for more than 48 hours. All these recommendations, as you can see, they're all consensus. They are not, we don't have any large scale RCTs or meta-analysis that can support these at this moment. So route of feeding, the best method is through the enteral route. And if this is not possible in a very sick, in a patient with malnourishment, we go for parenteral route. So why are we interested in feeding a critically ill patient enterally only? Why are we insisting on this? So as we know, in the fed state, there is no normal mobility of the gut, and the villus microanatomy is maintained. There is rich blood supply, epithelium and intracellular tight junctions are preserved, and they contribute to the overall integrity and barrier of the GIT. So along with it, when we give nutrients, there is this propulsive action that is happening, and that controls the concentration of bacteria within the gut. And there is secretion of bile, glycoproteins, then secretory IgA antibodies. And so the addition of these bacteria to the gut epithelium is reduced. And so the translocation of bacteria is reduced. So the healthy gut in the presence of food acts as an important antigen sensing organ in which the bacterial antigen is sampled, and this forms part of the mucosal associated lymphoid tissue as well. So when there is a gut disuse and in a fasting state, in the presence of a critical illness where the environment is not so good, low oxygen, low blood supply probably, these can cause an overgrowth of the bacteria, and the absence of food here can end up releasing interleukins and further inflammatory cells from the inflammatory cells can be released, mediators, cytokines can be released, and these cause the destruction of the epithelium of the gut, and then translocation of pathogenic bacteria can occur. So basically, it's more physiological, lesser complications, preserves gut mucosa, prevents bacterial translocation. We could say it is cheaper, but there was a study which said that TPN and enteral, there is no difference in. So this was 13 trials that studies that they put together for a meta-analysis comparing enteral and parenteral nutrition. Mortality-wise, there is no difference, but then infection rates are much lesser in patients who received early enteral nutrition, supporting what we just spoke. So should we delay, is giving enteral nutrition early good, or shall we delay it? Again, no mortality benefit. However, infection rates are reduced in early enteral nutrition patients. So coming back to our patient, this patient is on 70% FiO2 and he's receiving some noradrenaline. So can we still feed this patient enterally? So the contraindications that are there for this enteral feeding. So the fear with this here is, is he under any stress for the stomach or the GIT going into ischemia? Bowel ischemia is a problem if we are thinking that hypotension is a cause. So contraindications are uncontrolled hypotension and shock. So the important thing is it is uncontrolled and shock. Only in those conditions it is contraindicated to feed enterally. Uncontrolled would mean an escalating dose of inotropes is still not stable. So those conditions, we might have a risk for bowel ischemia. Again, there was a large study, Nutria 3, which included 2,000 and more patients. They compared patients who had uncontrolled shock with patients and fed them enterally versus parenterally, and they found that the complications of ischemia was only 1% in patients who received enteral nutrition, even in the uncontrolled hypotension phase. So basically, there is not much of a contraindication if patient has hypotension, but then we have to take it case by case. Uncontrolled hypoxia, hypercapnia, and acidosis, basically, if we don't have a good control over the metabolism, then we are more reluctant to start on enteral feeds. Active GI bleed, overt ischemia, high output fistula, abdominal compartment syndrome, a high gastric residual volume, all these are contraindications. So if oral intake is, summarizing the route, if oral, we first try an oral route. If it's not possible, early enteral nutrition. And if this patient cannot be fed enterally and the patient is severely malnourished, we go for early and progressive parenteral nutrition. Parenteral nutrition should not be started unless all reasonable strategies to improve enteral nutrition tolerance have been attempted. So now we have put in an NG tube, X-ray is taken to confirm it. Now, should we give bolus or continuous feeds? So there is again not a strong evidence to support either of these. Generally, continuous feeds are more comfortable to give, and it goes as a slow rate. So the nursing part, it is good, and tolerance is supposed to be better, and there are the times that they develop diarrhea is also lesser. So there is this fear that the enteral feeds in an AKI patient on CRRT or not on CRRT, they cannot tolerate the GI feeds. But this study has told that they are comparable, the outcomes in, the complications or the tolerance-wise, both are equal. There is not much of a difference between the the normal patients versus patients with AKI when we feed them enterally. Now, the next question is how much calories and protein shall we target? So the best method would be, you know exactly how much the patient is requiring, what are his energy requirements, and you provide that. So the gold standard here is indirect calorimetry. I'm not going into details because it was very well taken by Dr. Priyamvada. So we assess oxygen consumption, carbon dioxide in the exhale gas. As you all know, we don't have it routinely everywhere available, so it is a problem. Why this is important is that the phase of metabolism is so different in every patient who is critically ill. In one of the studies at severe AKI in ICU patient, 62% were hypermetabolic, while 14% were in a hypometabolic. So we can't have a all fit, one size all fit kind of formula here. So guidelines say we need to determine energy expenditure with indirect calorimetry. So if we don't have an indirect calorimetry with us, what do? We can use a PA catheter, which we can use the oxygen consumption and in this. Or there are some ventilators which could tell you how much carbon dioxide is coming out. Based on that volume, we can find the metabolic rate. So the drawbacks, again, like Dr. Priyamvada said, if there is extracorporeal utilization or removal of the carbon dioxide, then it's a problem. So what do we do if we don't have any of these? Then we have predictive formulas. And as you know, these are largely, they lead to over or underfeeding. The most correlating is the Penn State thing, but we go by the ASPEN and the ASPEN guidelines, which give us 25 to 30 kilocalories per kg body weight. This was a study which compared the indirect calorimetry with all the predictive scores. And as you can see, the bland albumin curve is, plot is all over the place, and there is not much of correlation between the two. So why do these formulas fail? Because of alteration in metabolism and hence the energy expenditure, which depends on what phase of disease and treatment it is. There could be changes in energy, which is happening minute by minute in an acute patient, like pain, fever, increased severity of inflammatory response. They could be on catecholamines. In a healthy patient, you give catecholamine, you know the energy expenditure will go up, but we don't know the pharmacokinetics happening here. Sedatives and beta blockers can reduce it. Gender, again, if the patient is on, patients with AKI and RRT fluid, we don't know how much we're giving. So largely these predictive formulas are inadequate and lead to under or overfeeding. So what do the guidelines say? If indirect calorimetry is there, you use isocaloric nutrition rather than hypocaloric. If we don't have this, we go by VO2 consumption in pulmonary artery catheter and VCO2 from the ventilator. And weight-based 20 to 25, 25 to 30, depending on the guidelines. So how do we achieve this goal? Do we start off with 25 to 30, or we have a way in which we give? So this is a study in which they saw a retrospective group from 2003 to 15, taking around 1,000 plus patients. All these patients were given nutrition according to indirect calorimetry calculated energy expenditure. And they actually saw how much of, they all had a calculated energy expenditure, and they saw how much of this percentage of calories were actually met by these patients. And outcomes they saw was mortality and length of stay and what. So it was interesting what they found, that the patients who got 70 to 100% of the energy expenditure that was calculated by the indirect calorimetry did much better. Their mortality is much better than patients who got less than 70% or more than 100% of the ones that were calculated by the indirect calorimetry. And similarly, protein-wise, as we increase the proteins, the mortality rate is coming down. So based on this, you can see here mortality rate Kaplan-Meier graph shows 70% of what we calculate, what the indirect calorimetry tells. If we feed them that, then the mortality is much better than overfeeding or underfeeding them. So the next question, how do we reach this target? So as we said, we have the acute phase and the acute phase is divided into two, early and late. So the early phase, we saw that we are having a situation of hypercatabolism, and nearly already the body is producing enough and more calories. So if we on top of that give the 70% of whatever we calculated already into the patient, then you know that patient is going to have a very hypercatabolic phase at that time. So we gradually start increasing. We give start from 25% of what we have calculated and slowly increase. By the fourth day we give them 100%. And there is no guideline to tell you that now the patient is going from acute phase to post-acute phase. We just have to see how the patient is improving, whether you're coming off inotropes, if there is some kind of stability, organs are improving. So that's how you know that patient has gone through this hypercatabolic phase, which occurs in the first 2 or 3 days, and they go in for acute phase. So in the next 1 week, we will be giving 100% of calories that they require. That is 70% of the 100%, whatever you get from the indirect calorimetry. So these are the guidelines. In patients with AKI, you give 20 to 30 kilocals, that is, and then start slowly. This is similar to non-ICU patient. Again, the level of evidence is very poor in this. So in our patient, he has gone into stage 3 AKI, anuric, no response to furosemide challenge. He's still requiring vasopressors, so we are planning to do CRRT. What are the metabolic and nutritional effects now? So we know that there are a lot of homeostatic functions that a kidney does. So they are all compromised. There is water electrolyte acid-based gluconeogenesis, erythropoietin production. Then there is metabolic acidosis. I don't have to tell you all of these. So these are basically functions of kidney that are being deranged. So importantly, the conversion of and the availability of non-essential amino acids is reduced. And there is conditionally, these become essential amino acid. So in CRRT, there is higher loss than intermittent dialysis. Membrane pore size is much smaller. I mean, the molecular weight of amino acid is much smaller. higher dialysate rate, longer duration, higher effluent rate, ultrafiltration, convective therapies, all these are much more protein loss it produces. And diffusive techniques lead to increase in catabolism of proteins. And glutamine is more lost because because of the concentration gradient. There is more of glutamine in the blood, so more of glutamine is being lost. Overall, around 10 to 15 grams per day is lost in CRRT. This again, Dr. Priyamada has taken how much is lost depending on the dialysis we use. So it's similar to indirect calorimetry. We monitor nitrogen balance for when we are giving proteins. Basically, it's a difference between the nitrogen intake to the loss. Loss can be urinary or other things. But for this, we need the creatinine clearance to be good, or we take from the dialysate, and then the effluent. If the patient is still producing some urine, then, in these patients who have a poor kidney function, we also see urinary nitrogen appearance. It takes into account if the patient is producing urine, you can see the urine nitrogen levels, and we basically see the pre and post dialysis urea and weight in these patients to get urea nitrogen appearance. And the catabolic rate is based on this urea nitrogen appearance. So based on this, we can classify patients as having a low catabolic phase. This would typically be a nephrotoxicity from a drug or something in AKI. They have low mortality rate, rarely require dialysis. Moderate catabolism may require dialysis. The mortality rate is 60%. And severely catabolic patients require dialysis. And these are patients who are typically there in the ICU. So patient is planned for RRT. Should we still continue feeding? Do we restrict proteins since there is a worsening of uremia and fluid overload? So basically, we don't have too many good RCTs to inform us on this. We have a lot of observation study, very low number of patients. Again, what they've seen, all these have compared low protein versus high protein, and they have typically said that urea nitrogen levels or the blood nitrogen or urea levels do not go up significantly. However, there is an improvement in the nitrogen balance. All these studies have told the same thing. So protein restriction does not appear to decrease urea appearance. Moderate increases in urea protein intake actually improves the nitrogen balance, but very large increases can lead to worsening uremia. Similarly, if we are using for CRRT, they only found that the aggressiveness of dialysis is increasing. So protein prescription should not be reduced in order to avoid or delay renal replacement in critically ill patients. So if we have uremia, which is going up in these patients, we actually have to evaluate why it is happening. Actually calculate the total amount of proteins and calories that the patient is getting, because the catabolism of because we might not be giving adequate proteins. Catabolism of body proteins for oxidation and energy production has the potential to be much greater contributor of uremia than an additional exogenous protein. Just 2 grams per kilo is not going to do much compared to the catabolism that is going to happen in the body if you're not giving adequate proteins. Glucose, which is impaired utilization, which shows impaired utilization, this also can lead to catabolism of the lean body mass. Other sources, GI bleed, corticosteroids, malabsorption, or dehydration, all these are the main things that we need to look in before we stop blame the protein. So this again, Dr. Priyamada has told, we have to see how much of calories are being added from the substrates that are there in the replacement and anticoagulants, because we don't want to overfeed these patients. As you can see, Prismasol has nearly 6.1 glucose in a liter. So proteins, so we saw the calories. Now proteins, what are the recommendation in AKI? Not on RRT, we increase gradually up to 1.3 to 1.7 grams per kilo. If patient is on IHT, 1 to 1.5. CRRT patients can get up to 1.7. These are all very low grade evidence comparable to ICU, general ICU patients. So disease-specific nutrition, generally no benefit, but in renal failure, you can have nutrition that can tailor to your hyperkalemia or hyperphosphatemia. If you're worried about overload, we can try nutrient-dense formulations. And also, if we want higher fat, which leads to better control of glucose, those formulations can be used. So these are various things that are available. So our patient is on the 4th day of, we have taken him off CRRT. He is still on ventilator. He's on alternate day IHD. Nurse informs us that the gastric residual volume is more than 500 in the past 2 hours. Should we stop feeds here? So this, we have now come to this place where patient is complaining of, we are having a situation of gastric feed intolerance, which is recognized by vomiting, large GRV, distension, and vomiting or something like that. So then we have to stop enteral feeds temporarily, consider giving prokinetics. So we try a maximum not to stop the nutrition and somehow try prokinetics, metoclopramide, erythromycin, and then try for post-pyloric feeds if it's possible. And in this way, we somehow try to maintain the GRV, try to maintain the enteral nutrition. If there is diarrhea, don't stop, don't blame the feeds immediately. We can reduce the rate if it's severe, stop the laxative, which is the most important cause of diarrhea, and we look for C. difficile infection, etc. So now where do we give parenteral nutrition now? So let's see a small scenario here. This is a 67-year-old lady with diabetes. She has undergone extensive resection of small bowel because of mesenteric ischemia. In the ICU, she has developed systemic inflammatory system responses syndrome because of sepsis, and the sepsis is developing. She's on vasopressors, ventilation, antibiotics, insulin. Plan for nutrition assessment shows that she's at risk of severe malnourishment. And so we were giving her low dose of tube feeds, but had to stop because of this worsening situation of escalating vasopressors, abdominal distension, increased intra-abdominal pressures, and gastric residual volume along with emesis. And we can also see she has wasting of muscles, and there is also electrolyte disturbances. So now in this situation, you can see we have to give her feeds while we cannot use the enteral feed. So this is where we would have an indication for enteral feeding, failed or contraindicated enteral feeding, or you want to increase a bit. This is not much of a recommendation right now, the supplementing of enteral nutrition with parenteral nutrition. So avoid early parenteral nutrition unless otherwise malnourished patient. You have this 3-in-1 or 2-in-1 or individual components. We need to watch for osmolarity. Complications, line infection, metabolic are very common in TPN because we can give the maximum dose. We can give whatever dose of TPN we want to these calories we want. Hypertriglyceridemia, hyperammonemia, cholestasis, electrolyte abnormalities, intestinal, all these are common here. So other substrates, I'm not going too much into detail. Glutamine is needed for nitrogen transport. It is needed for the immune cells and everything. So there was some evidence showing that glutamine improves outcomes. However, now we say only if patient has burns, extensive burns where there is exudation out of the body of these amino acids or severe trauma, then only we give glutamine. And otherwise, unstable complex ICU patients who have liver and renal failure, we should not be giving this because the mortality rate has been shown to be higher. Vitamin D, we replace only if we have a deficiency. All the antioxidants in high doses have been shown to cause toxicity. So we generally avoid them unless going on prolonged parenteral or artificial nutrition. Micronutrients, if we are giving parenteral nutrition, we have to start very early. This fish oil also, it's not a very strong evidence, but ARDS patients do benefit. So this is the scheme that we have. You start slowly and build up to 100% on the day 7. We watch for complications like refeeding, which we will see shortly. Thiamine is started early, micronutrients up to first 1 week. Glucose monitoring is very important. Initially, every 4 hours in the first 2 days. Insulin should be started and we should maintain around 140. So earlier, there was a small study which showed improvement in survival when a tight control of 80 to 110 was kept. But when this was put in a larger group like the NICE trial, they found that the mortality was very high. So now, as of now, we are targeting 108 to 140. And mind you, in the ICU, there is no role for glucometer. Every blood sugar should be monitored with the arterial blood gas. And revise your feeding, maybe you're overfeeding if your insulin requirements are going more than 6 units per hour. Other things that we have to monitor are these. Monitor for tolerance. Tolerance, there is no role for looking for bowel sounds. It doesn't mean that the bowel is working or not. And you go by physical examination, patients complain diarrhea, and do not stop feeding just like that if there is any of these. So what is refeeding syndrome? So it is a clinical complex which is accompanied by acute hydro and electrolyte and metabolic alterations because of a change in the insulin glucagon ratio in patient who was already malnourished as a consequence of bringing in nutrition at this point. It could be oral, enteral, or parenteral. So what happens basically is due to prolonged fasting and malnourishment, there is hypoglycemia, which leads to glycolysis, lipolysis, and proteolysis, basically insulin resistant states and hyperglycemic states. And there is intense loss and wastage of vitamins. There is, deficiency of vitamins and electrolytes. At this phase, if we start feeding these patients full feeds, and in the presence of predisposing situation like alcoholism, sepsis, etc., their glucose level goes up suddenly, and this induces an insulin reaction, increase in insulin states. This also has an antidiuretic effect, which causes sodium and water retention, and insulin causes a shift in phosphate, potassium, magnesium into the cells, and also there is ATP production happening now. So the phosphate levels come down. So the consequence of this hypophosphatemia is patient can have a cardiovascular collapse, arrhythmias. So this is a very life-threatening situation at this point. Hypokalemia can cause arrhythmias, muscle weakness, ventilator failure, similarly hypomagnesemia. Fluid overload can cause heart failure, and glycolysis, we need thiamine, which goes into a deficiency as well. So neurologically seizures, etc., can occur. So how do we prevent? It's most important to prevent this. So assess the risk, start slow, account for all the calories that patient is receiving. Patient could be also receiving a dilution in and giving the antibiotics or whatever in 5% diluent. So we need to account for all these calorie creeps. And then closely monitor and correct all the electrolyte abnormalities before you start your nutrition. Thiamine supplementation important. Monitoring with all the electrolytes are very important. Treatment as such is to not to completely stop feeding. You go slow, 5 to 20, depending on the severity of the refeeding syndrome, and gradually improve it over the next 1 week. Aggressively correct electrolyte deficiencies, give thiamine, and diuretics if there is overload. So to summarize, critically ill patients with AKI are at high risk for malnourishment in the ICU. Malnourishment and severe catabolism is associated with high mortality. Aggressive efforts should be made to initiate and maintain feeding. Enteral route is the preferred route. Monitor using indirect calorimetry and nitrogen balance if you can. Start slow and reach goals by 4 to 5 days, and watch for complications and refeeding syndrome. Thank you very much.
Yeah, it was an excellent, wonderful lecture by both the speakers. And Dr. Anusha's was extensive and informative for all of us. Back to first talk by Dr. Priyamada. Yes, it was really, there is no specific tool available for AKI nutrition. AKI nutrition is still a big research area to be concentrated on, and no RCTs available, no specific guidelines available. And what all the tools we use are mainly with CKD dialysis tools. And it's only right now indirect calorimetry, as you said, which is the facility which is not available most of the places. Really, the assessment is difficult, and you touched upon about how the pathophysiology goes on, and how to generally, based on physical examination, and whether the patient is catabolic, non-catabolic, and whether requiring dialysis or not dialysis, and the hidden losses, hidden gains, everything. It was a wonderful lecture, Dr. Priyam.
Thank you, ma'am.
Yeah, I'd like to endorse what Dr. Indumati said. Both the lectures were, seamlessly flowing into each other, starting off with helping us understand what causes a lot of the problems in AKI, with regards to nutrition issues in critically ill, and Dr. Anusha taking us through the full story of a patient with acute kidney injury. As Dr. Indumati mentioned, I think there are a lot of challenges that we actually face in the ICU. And as you mentioned very correctly, indirect calorimetry, while it is recommended by international ASPEN, SPEN guidelines, it is something which, having worked in Australia also, I know that even there, it's not there in all centers. And there are a lot of pitfalls also, ECMO, ECCO2 are some of them, but the oxygen sensor in the ventilator is very sensitive to higher FiO2 requirements, where the indirect calorimetry values that you generate would actually not be very useful. And in addition, there are a lot of other, if the patient has a chest pneumothorax or a bronchopleural fistula, the values which are generated by indirect calorimetry are not very helpful, and the evidence does not support. Actually, we don't really have, as you said, good evidence to say that this is what should be done for patients with acute kidney injury, even though it is coming as it's more like I would say a position statement rather than a high level evidence. And it is not available in many places, I would say, across the world. So we are usually back to the basics of targeting our calories based on 25 to 30 kilocalories per kg in the ICU setting. And one problem, to be very frank with you, in the ICU is weight. Is how do you get the weight of a patient in ICU? So yes, there are measurements, calculations based on length of a patient, a lot of inaccuracies which can happen with that. So that's a real life challenges that we do face in ICU, which could potentially lead to overfeeding in ICU. So that was one thing in ICU which we face, is really the challenge of knowing how much are we doing the right thing? Are we giving the right thing? And there are a lot of other factors which can play around with the decisions that we make in the critically ill. So I think there was one question in the chat box. One was about acute pancreatitis. Yeah, two questions. Acute pancreatitis, AKI, do we need to consider parenteral nutrition early? What is the role of TPN in such a scenario? Anusha, do you want to take that? I can also give a few points.
Yeah, so this is acute pancreatitis with AKI, right?
Yes.
Okay. So as such, presently the enteral nutrition guidelines are like now, and pancreatitis also, we have to start initially try to feed them enterally as much as possible. Only when we are not able to, and there is severe intolerance, the intra-abdominal pressure is going up very high, and the patient cannot tolerate it, only then we go for looking at other modes like parenteral. And also if we can't feed into the stomach, we can also try for post-pyloric feeds, NG, nasogastric and nasojejunal feeds can be given. So at maximum, we try to give enterally only. And there are also several other formulas which are specific for elemental formulas that are available specific for pancreatitis. So I think we should still go for enteral nutrition only as much as possible, especially in patients with a GIT kind of problem, because that helps a lot in preventing and controlling the sepsis down the line. I think Dr. Binila can add as well.
Yeah, I agree with you completely, Dr. Anusha. The golden rule in ICU, unless you've lost your bowel completely or you've got a high output fistula, is to try oral if possible, enteral by NG feeds if you cannot feed orally, and that is the way to go. The concept of resting the pancreas is no longer the way. So there is actually a very good study which compared NG feeds versus oral feeds in acute pancreatitis in NEJM, published in 2014 or so, which showed that you can feed orally or nasogastrically, no difference. So bottom line is exactly what Dr. Anusha said. Enteral nutrition, the way to go. TPN has got a very restricted role unless the patient cannot tolerate post-pyloric feed. So you will start with NG. If they don't tolerate it, you may push the NG post-pyloric. they still don't tolerate it, then you may consider TPN. And you may even give the patient some time. There is no rush to feed a well-nourished patient, even if they have AKI. Within, I would say even sometimes we wait 5 to 7 days before we actually start the feeds, unless the patient has got malnutrition. In those situations, you may try to start TPN if they're not tolerating enteral feeds within 48 hours. So that's my take on that question.
There is one more question in the chat box. Actually, Dr. Shubhashri is asking, is enteral feeding often associated with hypernatremia in practice? So do we need to have a watch on sodium content on these commercial feeds used in ICU? That's what she's asking.
Yeah, you can go.
I think, see, when I look at hypernatremia in ICU, I think there are many other causes, and nutrition will probably be the last cause of the hypernatremia in the ICU. So I would not, put my eggs on that it's hypernatremia because of the feeds. Usually the hypernatremia is because of third spacing. It's because of maybe iatrogenic uses, maybe because of overdiuresis, a lot of other causes, and nutrition would be the last one. So I wouldn't actually, put my things on the enteral feeds. Honestly, in CMC, we don't use commercial feeds because it's quite expensive. And most of the feeds which are made here and used for patients is made by our dietary departments. And we haven't faced this problem of high sodiums.
Yeah, I support that because basically often in the ICU, the reason why patient develops hypernatremia, nutrition is the last cause. And even without compromising, even if you don't have the renal specific feeds, there are ways to tackle the hypernatremia. For example, the saline we give as infusion. Multiple patient on multiple infusions, if we give normal saline, that is going to be, say 1 liter of normal saline contains around 9 grams of sodium chloride. That's going to be double the daily requirement of an average individual. So we can actually cut down on the infusates because many of the drugs might be compatible with half normal saline. And if there is any other diluent, we can actually cut down on the simple infusates, and sometimes certain drugs, the sodium content of certain infusions, certain IV infusions are going to be on the higher side. For example, cephalosporins, they contain quite a large quantity of sodium. So if we can go for some other replacement, and if it is not a very critical thing, continuing with the same drugs, hypernatremia can be easily managed. And most often, it's not the food that is going to cause the hypernatremia. And the other issue is when we give enteral nutrition, yes, there is a definite chance of development of hypernatremia because the problem with the enteral feeds is we don't really have any kidney specific feed. The higher the osmolarity, the greater will be the sodium content. For example, there is a patient with AKI who is non-oliguric, who is not on dialysis. The amount of osmoles excreted becomes a function of the urine volume. For example, we are feeding 1200 osmoles and the patient cannot concentrate the urine. So technically the osmolarity of urine is truncated at 300. So patient might require 4 liters of urine to excrete that 1200 osmoles. So this is an area where you need to be careful because we might end up developing hypernatremia. As we know, 4 liters usually happens in the polyuric phase where actually none of these issues will be there because the patient is wasting sodium. So that we need to be careful when the patient is actually output is truncated and we are giving the patient TPN, then probably we will have to devise individualized strategies to deal with that.
I just have one comment to make about proteins in ICU. It is an area where, as was mentioned, a lot of the data which has been extrapolated is from studies which are not directly looking at high versus low protein in AKI patients, but along the way they got the conclusion, like from the renal study, that it didn't have any difference in terms of mortality. But just for the trainees who may be joining, who have joined for the session, there's a study which is published in the Lancet last year, which is called the EFFORT study, which looked at high protein versus low protein in critically ill patients. And they found no difference in outcome. And even in the subgroup of patients with AKI, they actually found no benefit. But they define, you need to know what the definition of high protein which they use was more than 2.2 grams per kilogram of protein versus 1.2 grams per kilogram of protein, which is what we use normally. And there are some 3 or 4 big trials. There's a replenish trial, a target trial, and a precise trial, which are looking at high versus low protein, and that's ongoing. So maybe in a couple of years we'll get more information on this. And apparently they are including patients with AKI, so we'll hopefully get more answers. Yeah, but I think the goal is to stick to 1.2 to 1.5 grams per kilogram in critically ill. Per kilogram, should get that.
Can I ask a question, Priyambada and Anusha? This prescription for the nutrition, does it vary with the etiology of AKI or something? Like we have patients with more often coming with some poisonings and all. Does it differ with that? That's one question. The second question is, we do have patients of pregnancy and AKI. How do we go about in that group of pregnancy and AKI who most often these pregnancy and AKIs are in AKI stage 3 on dialysis. So is there any difference in this group? The first question is with respect to etiology, because in our setup, we get to see paraquat poisonings quite often. We have about 350 paraquat poisonings online who are liver damaged, kidney damaged, lung damaged, 70-80% mortality and all. I mean, so anything on this? Yeah.
Regarding the pregnant patients with AKI, what we need to keep in mind is even otherwise the protein requirement in pregnancy is going to be much more higher. So the recommended daily allowance for an average non-pregnant female 0.83 is going to be sufficient, provided the patient is taking a high quality biological value protein. But whereas we have to make allowance for the AKI, especially on dialysis, because the protein requirement is going to change when we put the patient on dialysis. You have to make allowance for the pregnancy and you have to make allowance for the dialysis. If the patient does not have dialysis requiring AKI, most of the time sticking on to the upper limit of recommended daily allowance for the pregnancy is sufficient. So the other situation is when the liver is gone, the entire nutrition is going to be decided by the requirements of liver. So that's a scenario where actually the renal replacement, we might be putting the patient on renal replacement therapy. We might be putting the patient on CRRT, but all the nutritional requirements are to be according to the status of the liver disease.
Right.
Yeah, I would like to also add that we don't have, I mean, most of the studies which are done, they typically exclude patients who are pregnant. And so we don't have any clear evidence that what to do if an AKI patient who's also pregnant comes into the ICU and how it goes about. But I think largely we would go by what Dr. Priyambada was telling us. We need to account for the pregnancy as well as if AKI and if patient is on CRRT, how much is being lost. And yeah, that's how it is. And regarding the poisoning, the etiology as such, there is no difference. It's only the catabolism, what type of catabolic phase that the patient is in, whether they are metabolizing a lot or not too much. So you were asking about the proteins as such, so that you can actually go by the nitrogen balance, which is not very difficult to do. I think if you are getting urinary nitrogens, you could go by seeing that and see if you could get a positive or not, or at least not if you are in a negative nitrogen, you can have a rough guide what to do. But again, there are several factors which are happening in the ICU, so you need to see what your situation is. But by and large, according to etiology, there is no specific adaptation that we do for AKI as such.
Probably the paraquat related AKI, probably there might be some catabolism. So not going to be a non-hypercatabolic AKI. Probably some at least a moderate degree of catabolism is going to be there with paraquat, because that is something which affects the multiple systems. And unfortunately, there is not much data on paraquat because it's like more of a phenomena that is confined to certain parts of India. So evidence definitely is not going to be there. Probably we'll have to take the overall assessment. How many systems have failed? And obviously, when actually 3-4 paraquat has affected the lung, kidney, as well as the liver, so invariably a certain amount of catabolism is going to follow. But unfortunately, we don't know. There actually we need, as Anusha said, the nitrogen balance studies and all.
Yeah, practically it becomes difficult, no, I mean, for us.
One point is
Swanlata, you want to ask anything? Swanlata?
one
Okay,
point is when in parakeet poisoning there will be GIT necrosis. We may not be able to feed them enterally or orally. Initially, we had to do IV fluids, and later on, if the patient survives that long, they may have to resort to parenteral nutrition. That is in case of severe parakeet poisoning. But usually, the mortality of parakeet poisoning is very high. Patient will not survive that long. Before that, patient will succumb to death by respiratory complications.
I've seen only one patient surviving in the last 3 years or so.
We have about 370 patients of paraquats. So that's very common here. Suicidal tendencies, 60 to 67% is the mortality rate. Rest of the 30% survive. But as is being said, they do stay for about 7 days minimum in our ICUs. We need to take care of the nutrition as well. That is important. But I want to ask Vinudha, Vinila, and Anusha. See, you are from institutional setups where this support is. I'll just
Sorry,
mute.
there's a lot of echo.
I muted Swanlata. Yeah. So, I mean, institutional setups. We come from public sector hospitals, government institutions, where, we cannot even, Anusha, think about urinary nitrogens and all these things. I mean, nothing, absolutely nothing. Practically, when you come down to the bedside of a patient, this I don't think that I'm over expressing, but then superfluous it becomes for us. And then to put the patient in a right perspective of nutrition, we just want just quick tips of like 1, 2, 3 probably, which can befit by and large a basic AKI situation. And the type of patients that come to us, paraquat is more, pregnancy is more. Obviously, the economic status of the patients also very poor. So we cannot force them to have some enteral things, and government supply also will be very, interrupted, not very available and all. So many shortcomings when it comes to nutrition aspect. Of course, is very important, but then are there any tips that are practical things that we can think about which customizes to the requirement of our groups?
Ma'am, I completely agree with you. I think in CMC, we do not check urine nitrogen and assess the catabolic state. To be very frank, it's one thing which I find very fascinating about critical care is what value I get in the morning may not be the value I have in the evening. The patient state is so dynamic that can one value actually guide my patient management? More and more, there's a lot of focus on individualized critical care, individualized prescription, whether it's ventilation, whether it's nutrition, depending upon the patient. And people are more and more realizing whether there's a benefit of actually, doing an hour by hour analysis. Till now, we don't have data. And to keep it very simple, large studies which have looked at, let's say, high versus low hypocaloric versus normal caloric, or whether you give continuous versus bolus, whether you give high versus low protein. Globally, what we have seen is there is that higher the calories, probably worse the outcome. So in general, the principle is, if you ask me for a patient with AKI, few things I keep in mind is fluid restriction, because especially the ones who are in stage 3 AKI, there's a risk of them going into fluid overload, which we know in critical care and critical illness can increase your mortality. Just having a positive fluid balance can increase your mortality. So I would be cautious about the amount of fluid that I give. And I tend to give more, rather than giving 1 calorie per ml feeds, I may give maybe 1.5 to 2 calories per ml feeds, so that I can decrease the amount of fluids that I'm giving. That's number one. In terms of calories, I would say as of now, irrespective of the scenario, we should aim. In fact, actually, there are studies which have actually shown that hypocaloric feeding is as good as hypocaloric feeding means like in critical illness. So where a lot of patients are catabolic with or without AKI, is as good as normal caloric feeding, but it's still not, the norm. And hence the recommendations are, and that's why actually they actually say it doesn't matter when if you start slow, as long as you reach the target maybe 4 to 5 days down the line, The goal should be to try and reach 25 to 30 kilocalories per kilogram of the body weight of the patient. Whatever you measure, but for obese patients, there is a different calculation, which is already mentioned. And for proteins, I would aim for 1.2 grams, 1.2 to 1.5 grams per kilogram of proteins intake per day. So this in general would be the protein, and and make sure that my carbohydrate and fat would be maybe in a 70-30. That is usually adjusted by the dietary, and it doesn't really matter what the situation is. So that is the general global formula that I use for most patients in ICU, and mainly focusing on minimizing potassium, making sure my metabolic parameters are okay, minimizing, restricting my fluids, and ensuring they're getting optimal proteins without giving them too much hypercaloric feeds or very high proteins. I don't think that is, as of now, we don't have sufficient evidence to back that up. So that is my take on it. We do not measure urine nitrogen. We do not do indirect calorimetry. I mean, other things which can affect, so there are ventilators which can actually do this indirect calorimetry measurement. But as I mentioned, there are a lot of pitfalls with that measurement. So I mean, like we, as an institution, we have not invested in that, even though there's a lot of push to do that.
Okay, one more question. Anusha, you want to answer? Yeah, please.
Yeah. So I was just the discussion was interesting, and we also don't do nitrogen balance on a regular basis. Only if we see that when we are, in spite of giving what we are giving 1.5 grams per kilo we are giving, and we still see that the patient is still catabolic and he's not like showing much of improvement, then we might go. So as you can see, what I feel is we know how to manage blood pressure. We give an inotrope, we know we have some targets, we see it immediately, and then we can go up and down, I know, and we know what to do with the ventilation, patient adjusted. But nutrition and all is such a difficult.
Is there a voice break, or am I not able to hear?
That we do, or also we direct endpoint.
Okay.
Am I
There was
audible?
a voice break. Yeah, it was
Now?
breaking
Yeah,
a
I
little
don't know
bit.
why. Yeah. So what I was saying is, like, we know how to manage hypotension. We have a target blood pressure. We give, we titrate it up and down based on that. And we also have patients on ventilator who are getting hypoxic, and we know what to do with that. But we don't know what is the target with nutrition. So how do you titrate the nutrition based on what do you evaluate for a patient with nutrition? So these are all gaps that we have, that we don't know how to actually, because nutrition deficiency now, we don't know what are the effects. Is it due to a deficiency in nutrition that this patient is a big question. We don't know. These are all the things that we have to support our the way we give nutrition in our patients. Like individualized, if you say, then you have to, I mean, we give a weight-based calculation for nutrition, then we are going in for an one-size-fits-all kind of situation. And so individualized would mean that depending on what is the energy requirement for each of the patient, then we give that. So I don't think we are still reaching there yet. And in your particular situation, I think you need to see whether the patient is already malnourished also. So we cannot start very early with very high feeds. So all these factors, I think close monitoring and then feeding is very important in the kind of situation that you are telling us. Otherwise, it's
Yeah, one more question to Priyambada, probably Anusha or Vinila can take it. How often, see, you said the outside, Priyambada, that the scoring systems which are there are not much validated. I mean, in the sense, they're not of
Yes.
presently. But even if we use those systems, how often that we are supposed to use these systems to assess the nutrition status? If at all we put them into use, is a scoring system to be done? How frequently and all this?
As
So
far as I'm in ICU, what we do is the
Yeah,
scoring
exactly.
system. If the Nutric score is a score which is fairly easy to do, and it's usually done at admission. We are not doing it repeatedly. It is at admission to intensive care. It is done to find out if the patient is at risk for malnutrition, that is all. It is not done on a repeated basis. Whether it's like Nutrix score, I think is in India most widely used because it's easy to do, excluding the IL-6 values. The SGA and the NRS are a little more extensive and a little more challenging. I mean, it's not challenging to do, just more time consuming, which is sometimes very difficult in our settings. So at admission is what is recommended for Nutrix score.
Okay.
At admission.
I think the questions in the chat box are answered, no, Dr. Swati?
Yes, ma'am. Actually, there were 2 questions. That's all.
Yeah.
No more questions. Thank you so much for elaborate and extensive sessions, Dr. Premada ma'am and Dr. Anusha ma'am, and thank you chairpersons, Dr. Indumati ma'am, Dr. Usha ma'am, and Dr. Milla ma'am, for providing such valuable insights. So I think we can end the session. Thank you so much. Thank you, Win India, for organizing such beautiful and wonderful sessions on such topics like nutrition. It is very informative and very useful. Thank you.
Thank you. Thank you so
Thank
much, everyone. I think it's been an amazing session. We have learned quite a lot. And thanks especially to Dr. Premada, who stayed in the program. And this is a series that we have been doing. This is one of the last, as Premada said, we're going to take a break after this regarding the nutrition, but we have been conducting the nutrition sessions for the last 1.5 years. So it's been amazing association that we have had with the whole team of the Nutrition Association within India. So thank you everyone. And there's a long way for us to understand, but yet taking naive steps and baby steps is crucial and essential. So thank you everyone. Special mention to Binila and Anusha have joined us, and of course our own Indumati and Dr. Usha could not join. Okay, it doesn't matter. And thanks Premada. Thank you so much. Thank you everyone. Thanks the tech team. Thank you so much.
Thank you.
Good night.
Thank
Yeah.
you.
Thank you. See you. Bye.
Bye. Good night.
Bye.